So we're going to talk about hypothalamus. That part is not working, but I believe I can draw. Can I draw? Yes, I can draw, which is more important than being able to advance. All right. So here's everything that we've covered, and it's the only things that I put up onto the schematic that I built. And when you think about it now, first of all, everything in it should be familiar. But really what we've done is talk about all the ways that information comes in. We've talked about the way we affect our output organs, which are essentially muscle, smooth or skeletal, glands that we innervate, and organs such as the adrenal medulla, that's essentially a target organ that it functions as an endocrine function. We don't need to know that I haven't synced my file storage device. And along the way, we've talked a lot about how all the sensory information comes in, and it comes in multiple types of information. We had taste, we had smell, we had auditory information, we had visual information, we had all the different types of somatosensory information. And we brought that all up gradually and eventually through multiple steps to cortex. And then once in cortex, we have basically moved it through multiple different modules in intersecting networks, so that we both use it to generate a complete sense of what's going on to us and around us, and then made decisions about that based on both immediate information that we got from, inputs, thalamus, cortex, as well as context, which includes hippocampal input about prior memories, amygdala input, which tells us about what type of, emotional level response you're going to have to it. So we've got all of the various pieces now. And the one type of effector that we don't have yet is we don't have the autonomic equivalent of the corticospinal tracts and the rubrospinal tracts and the vestibulospinal tracts and the reticulospinal tracts, which are all the things that we talked about that control our somatic motor output. Okay? So we talked a lot about how you went from touching something hot with your left finger and pulling your hand back, knowing whether or not you burned yourself, and if you burned yourself, walking across the kitchen, turning on the cold water with your other hand and sticking your burnt fingertip under the cold water. Okay? We know how to do all of that based on the immediate pain response, the perception of pain, where the sensation comes, the memory about what happens, the sense of how bad is it? Is it bad enough that I have to do that, or is it not so bad that it won't hurt, it won't blister, I can keep right on cooking my eggs, versus do I have to go put it on because it's much worse than I expected? All of that's based on prior experience. The first time you burned yourself, you had no idea what to do. But now when you do it, you exactly do. And you know how to get that motor output. But what you don't know how, what we haven't talked about yet is when you do that and you really burned yourself badly and your heart rate goes up and you start to sweat, how's that controlled? We know what the output sources are for that, right? What are the output sources? They're all motor. They have to come out. That's the only way you influence anything is through motor type output. And where's that going to be located for us? If I'm talking about my heart rate going up, what am I going to do? Yeah, I'm going to do vagus. What am I going to do in my vagal? Less so. And where's my vagus going to come out? Yeah, so in the medulla, at what nucleus am I going to shut down a little bit? Yeah, dorsal motor nucleus of the vagus is going to decrease its activity. Something has to tell it to be quiet. We haven't talked about how we do that yet. That's what we're going to do today. What else is going to happen? What's going to control sweating? Sympathetics, okay? Where are they going to come out? Yeah, spinal cord. Which set of neurons? Yeah, the intermediolateral column. Okay? What's the neurotransmitter for these? Acetylcholine. What's the neurotransmitter for these? Acetylcholine, these are preganglionics. They all go to a ganglia where there's ganglionic transmission, and the difference is the postganglionic fiber, okay? So these are all cholinergic output neurons. We haven't talked about how we got anything all the way down to the cord, except in the vaguest possible sense, okay? So that's what we're going to do today, is what's the next level of processing where this is going to happen? And the answer is hypothalamus, okay? But, I have to learn to not push that. I don't know why it's not behaving, but we'll deal with that later. But before we get to that, I wanted to touch on a little bit of pathology that I didn't talk about at the end of Wednesday. Some of what I had on Wednesday, I've actually moved to come on Monday next week because I think the link will be better there than today. So what level are we looking at here? Give me a bunch of structures that are relevant. Hippocampus, which side do you see hippocampus on? Right side. Tell me where? Here I'm at the midline. Where do I go to get to it? Yeah, so that's the very anterior portion of hippocampus. Okay? What's this? Amygdala. What's this? This? Blood vessel? MCA. This? Anterior. This is going to be our hypothalamus in the walls of the third, but here is our nice big fat amygdala on the other side, right? So, I've learned my lesson. I don't push that. I have to walk over here. So what do you see here? Or more accurately, what don't you see here? Hippocampus, anything else missing? Amygdala. How about other things that don't look so happy? Yeah, which part of cortex? Well, so we're missing, so here we would expect to see our amygdala and then our hippocampus, right? So this is the amygdala here. Here's our hippocampus, fictitious, right? But what's the worst looking cortex you see here? Temporal, what part of temporal? Medial. What does it have its name? Yeah. Hippocampal gyre is like wafer thin. So you come around the inferior, so this is superior, middle, and inferior temporal gyri. Inferior temporal gyrus looks pretty bad. Middle is pretty bad. Superior is not too bad. The insula is a little open. Sylvian fissure is a little wide. And in fact, all of the cortical ribbon is thin, but this is by far the worst. Okay? And this is actually somebody with end-stage Alzheimer's disease. The other thing you can notice, what else do you notice as you look here? Let me just go back to this. Oh. Go back to this person. Yes, size of the ventricle, but look specifically at this relationship. Here's the corpus callosum coming across. Here's the top end of the caudate. There's a little bit of white matter and lateral ventricle there, and even this one is a bit atrophic here. That's a bit big. But when we look at this person, there's this real sense almost that the basal ganglia have slid downwards. They really haven't. What's happened is that the ventricle has risen above them because there's loss of both cortex and white matter. Look at it. There's really, think about this. Here's the cingulum, the white matter bundle under the cingulate that's going to wrap all the way around and project it into our cortex. That's awfully small. The whole volume of white matter here, there's just not enough white matter in this temporal lobe or frontal lobe. Okay. This is end-stage Alzheimer's disease. And in fact, the neurons, well, I feel like I'm chained to the podium now. And in fact, when we think about the spread of one of the two classic lesions in Alzheimer's disease, which is the nerve fibrillary tangle, that the MDs heard about from Deniselko in PATH last year, and somebody will talk about dementias in the last block of the course, and you'll hear a lot more about them. But pathologically, these begin in the layer 2 neurons in the entorhinal cortex. That is the first place in the brain where they appear. And they propagate from there through the hippocampal formation, and we now know that they actually propagate one neuron to the next, so that they are prion-like. Protein aggregates lead to the formation of protein aggregates in the next neuron, and we can actually watch them move, spreading. And so that they begin in the parahippocampal gyrus, spread into the hippocampal formation, and then from there spread out through high complex multimodal association cortices, with the primary motor and sensory and visual cortices being the last ones affected, and that's what we consider to be the highest stage of disease. What do they look like? Well, in fact, here, this is a patient, this is immunohistochemistry for tau, so you can see the tangles, but this cluster of neurons in layer 2, right up here, this is one of the characteristic features of the entorhinal cortex. And these neurons, which should not have any of that abnormal protein in them, those are the neurons that give rise to the perforant path. So if those neurons are lost or dysfunctional early on in Alzheimer's disease, what would that do to the hippocampus? What do you lose if you lose the perforant path? Is perforant path input, output? What's the organizational conceptual structure of the hippocampus? Comes in via the perforant path. Perforant path goes where? Dentate gyrus. Dentate gyrus projects predominantly to CA3. CA3 through the Schaefer collaterals to CA1. Yeah, this is really good. It's only like a 48-hour recall. Okay? This is like 3 objects at 48 hours. Okay? CA1 to subiculum through the fornix, out to mammillary bodies, and as we'll see on Monday, the septal region. Okay? So if you lose the perforant path, what are you mostly losing? All your input. If you lose all your input to your hippocampus, what happens to your memory skills? You don't get them. You can register objects because that's not a hippocampal function, but you have the no ability. Your immediate short-term recall goes. Long ago memories from childhood? I know they're not so long ago for you. What happens to them? They're okay. They're not held in hippocampus at that point. Okay? So the early component of Alzheimer's disease with memory disturbance comes from this anatomic specificity of the first cells being the first cells to go. The other amygdaloid syndrome that I wanted to mention is this one, named for Kluver and Busey, up on the top 2 corners there. They actually described this when they were doing lesion studies in monkeys. And what they showed, again, was that anterior temporal damage, especially bilateral, same way the hippocampus, you need to hit bilateral. Debbie, sorry.
I don't know about Alzheimer's disease, but in certain dimensions, I thought you can have phases where maybe you have more memory and less memory, or is that not?
So it depends. So some of the neurodegenerative diseases spare memory until later. So there's so dementia with Lewy body disease and dementia with Lewy bodies has some level of fluctuation that probably has more to do with fluctuations in attention and is more a frontal phenomena than actually true memory, because memory testing doesn't fluctuate in the same way. Yeah, but those are not, it's not so much true memory, but it's the complex need to use frontal lobe in order to get information in. So the critical thing here, and it relates a lot to what we talked about in HM on Wednesday, is that to see the deficits from these structures, both the memory disturbance from hippocampus and the behavioral disturbances, as you see with the amygdaloid lesions in Kluver-Busey, the lesions have to be bilateral, okay? So that these are both sharing responsibility for the tasks, left and right. That's really different than when you think about other cortical functions or cerebellar functions or brainstem nuclear functions, where the left deals with either the left side or the right side, depending on where it is, in what type of structure. And there's sort of, you have coverage of one part and coverage of the other. Memory and the behavioral responses, and as we'll see, the autonomic responses, tend to be represented bilaterally, and it's really only bilateral lesions that typically give you significant deficits, because you are able to make use of the other side circuitry in that sense. So the combinations that are seen in the monkeys here when these lesions were made was the critical one, as you would expect, as I said before about the amygdaloid function, is the loss of fear response, lots of oral exploration, and hypersexuality in these monkeys. Does this happen in people? Well, it does. So it can happen if you have bilateral procedures, which people tend to avoid, but sometimes one amygdala turns out not to have really been functioning, but nobody knew, and then the neurosurgeons do something on the other side, and the fact that the intact, non-operated side was not functional is revealed by the emergence of the syndrome. But the far more common is herpes encephalitis. So herpes infections in the CNS in the adult, not neonatal herpes encephalitis, but in the adult, tend to come and affect orbitofrontal and anterior temporal regions. They are hemorrhagic, they are an infection of the neuron, but as part of the response, you end up with lots of tissue damage, hemorrhage, and tissue destruction. And if you have bilateral involvement of the two anterior temporal lobes, you are at risk of having bilateral amygdaloid injury. The other is because the temporal lobes sit right up against the anterior wall of the middle fossa. Acceleration, deceleration injuries that smack the brain up into it have the potential to cause contusion, and if they are large enough, damage both amygdala and give rise to this. So it is seen clinically in these settings. Herpes encephalitis, if diagnosed accurately, gets treated with acyclovir. When acyclovir first came out, it was felt to be too dangerous a drug to give to people without a histologic diagnosis. So as neuropathologists, we used to get brain biopsy to rule out herpes encephalitis, which was really challenging. But now, basically, the combination of either CSF PCR or it's felt to be a safe enough drug, so it gets added empirically when people come in with the question of meningitis. In addition to antibacterial coverage, acyclovir is added until CSF PCR comes back negative for herpes. Eventually I will stop the habit. And this is just the most recent, which is now about 2 decades old, example of somebody who died with herpes encephalitis. Yes? Yep. Can't. Because, so in theory, one could do it with the equivalent of a WADA test and try and present fearful stimuli and do that, but it's not done. Because this is very, very rare, but there are case reports where it turns out that, there must have been a cryptic old stroke. Clearly if you look by imaging and one of them has had a prior small embolic infarct, you'd be aware of it. But sometimes there aren't particularly good alternatives. You need to evacuate a hematoma from trauma. There's a tumor that needs to be biopsied, or so on. So here you can actually see the hemorrhagic necrotic area on that side. Here there's not as much damage, but there are these beginning punctate foci. And I think there's the olfactory bulb here is disrupted, and there's some early hemorrhagic injury here as well. This is an old case of herpes I had probably when I was a resident. Okay, so this is a slide we showed when we were making that transition out of brainstem and into the beginning of deep gray. And I introduced the term diencephalon. The diencephalon is immediately adjacent to the mesencephalon, which is the fancy name for midbrain. Remember, we've got that transition, that smooth, continuous flow. If we think about the superior cerebellar peduncle fibers, they've come from a dentate nucleus on one side, they cross the midline in the upper portion of the pons and low midbrain, and then they wrap the red nucleus, and then they move right adjacent up to the thalamus. To what nucleus? Cerebello-dentatothalamics. What type of information? This is more than 48 hours, so recall isn't so good. Yeah, they're going to go to ventrolateral nucleus. They go to VL out of the VAVL motor complex. Okay. So when we talked about that, we talked about the thalamus, and so we're not going to talk about thalamus anymore, although I can't stop mentioning things as we pass them. And we have also already talked about the ventral thalamus. That's the subthalamic nucleus. Anatomically, it's connected. It's sort of next to both that and basal ganglia, but we covered it when we talked about basal ganglia. It's the critical intermediary for which of the pathways? Indirect pathway. It's what sets the indirect pathway apart from the direct. That externa, globus pallidus externa to subthalamic, back to interna, which changes the sign so that you now have tight control of interna because you have both the ability to make it go up and down, fine-tuning it. And we'll come back at the end of this morning to the power of fine-tuning like that in terms of other hypothalamic functions. So now we're going to talk about the rest of the morning, essentially hypothalamus, and then, because I have no other place to put it, and it is somewhat related, epithalamus. So these are other things hanging around. So hypothalamus, where would you expect it to be? Below, right? It can't be exactly where the subthalamic is, but it's sort of below someplace. And so here, let's think about what color coding has been used, and it's still down at the bottom. But if you look there, that grayish oblong football is our thalamus, right? We are looking from where? Well, here's the clue. If you were looking and see the aqueduct, where must you be? You must be on the midline, okay? The aqueduct is like a millimeter wide. So you're only going to see it if you're within a millimeter, maybe a millimeter and a half, of being on the midline. So we're standing on the midline. So we are seeing which thalamus? What hemisphere is this? Right, so we are looking at the right hemisphere, and that thalamus is sort of tucked in there at an angle with the pulvinar back here sort of hanging out towards us, all right? The blue here is the epithalamus that we'll get to at the end of the morning. Down here is sub, and in front and inferior to the thalamus, in green here, is the hypothalamus. So what would mark the medial border of the hypothalamus? What are you looking into? Third ventricle, okay? So you've got the third ventricle, and as you go lateral from the third ventricle into brain, you're wandering through the hypothalamus. The first part you would come to will be the, it's not a trick question, medial hypothalamus. Then you will come to the lateral hypothalamus, and then you will be out of the hypothalamus, okay? So we're going to have this zone that sits on either side of the thirds. So finally, we've got a structure that has at least a visible boundary on one side, okay? It's a long time since we saw something that had a visible boundary, okay? Everything has all been just up against each other, okay? So where is it going to be? So what we arbitrarily define, it's not particularly arbitrary for the anterior boundary, is the front wall of the third ventricle, okay? The posterior boundary is a line drawn at the posterior point of the mammillary body, okay? So now you can think about how far that's going to be. Is that a couple of millimeters? Think about the brains. That's bigger than a few millimeters. 5 centimeters? No. 2 centimeters? Yeah, it's about 2 centimeters, probably a little less. Depends a little bit on, who the person is. But we're talking about a pretty small structure there, okay? And it's going to go far less deep laterally than that. There is this hypothalamic sulcus that you can sometimes see that defines the upper boundary. This coming at us right here is the anterior commissure. So these fibers here are the fornix. These are the postcommissurals. Where are they headed? Mammillary body. So that's hippocampus to hypothalamus, okay? Tucked in right over here, deep behind us, we've got the temporal lobe, right? Sitting there. And what sits right here in the anterior temporal lobe? Deep underneath the cortex, in front of the temporal horn of the lateral ventricle and slightly superior to it? The amygdala. And we've got that amygdalofugal pathway that loops right out of the temporal lobe and into the adjacent structures along the wall of the third ventricle, the amygdalofugal projection of the to the hypothalamus. Very tightly connected. We also have what else to come out of the amygdala? The stria terminalis that makes a loop just like the fornix and comes into the hypothalamus. All right, so when we think about it from the surface, we've got to think about where those landmarks will be. So the posterior boundary is going to sit right back here at the posterior edge of the mammillary bodies. The anterior is going to be right in front of the chiasm. And if you take those brains and look up, if I go back on the schematic, here's the chiasm, and coming right superior from the anterior edge is this front wall. And that front wall is known as the lamina terminalis. It's different than the stria terminalis. Okay, we've got the lamina terminalis. So when we look on the surface and look down, we can know that the lamina terminalis will be sitting right here. That's the anterior boundary. We've got the mammillary bodies, and then as we go, we're going to have a medial zone and a lateral zone. And the boundary between the medial and lateral, as we'll see in a moment, is going to be defined by nice white matter bundles. And what are the white matter bundles that we have coming in that are going in through this area down to the mammillary body? Fornix. And what do we have coming out of the mammillary body? Where does the mammillary body project predominantly to? Anterior nucleus of the thalamus, and that tract is the mammillothalamic tract. So those are essentially lines that are going to tell us where the midpoint is between medial and lateral. Okay? It's really hard to get out of these habits. So if you look in the anatomic planes here, what is this? Foramen Monroe. What is, can't see it well. What's this? Yeah, it's fornix. Okay, it's a little tough to see there. What's this? Anterior commissure. Optic chiasm. What do you think that right there is? What's been cut right there? Yeah, people are moving their hands like this. Everything has a name. Anterior communicating. It's the anterior communicator. It's been cut right there. That's the anterior cerebral arcing forward. Okay? This is? Where's it coming out? What's that? Midbrain, cranial nerve coming out, going forward. Oculomotor nerve. Okay? But now, what are we looking at here? That's the sort of hypothalamic sulcus. So this is the walls of the hypothalamus, right? Up to basically where? Right about there. That's the mammillary body. Okay. Notice, see this space? What might you call that? It's a recess. Where is it? What's below it? Optic chiasm. So how might you call it? Suprachiasmatic recess. What's this? We'll talk about it in a little bit, but anybody remember this? Anybody who took endocrine remember this? No, it's not the pituitary sits down here, but that's the stalk of the infundibulum. And so this is the infundibular recess. Okay? We'll talk about the one that's back here. This is the pineal gland. We'll come to the pineal later this morning. All right, I'm going to push the correct button. All right, so here's the same structure visualized in the midline. How do you know you're in the midline? Aqueduct. If you find the aqueduct, you know you're at the midline. Here it is right here. This is, right above here, tectum. All right, so here is our mammillary body. Here is our chiasm. Here is our infundibulum actually coming down to the pituitary gland. Why does the pituitary gland have two components to it? Yeah, because the pituitary gland has two components to it, and they actually show up slightly differently on imaging. Okay? Look at that. Reality. Okay? All right. Can't really see. Here's, what is this? Fornix coming around. And what's that right there, Carly, running across? Anterior commissure. It's like you can actually see these things for real. And so the walls of the third ventricle are going to be right here, here to here. That's where our hypothalamus is. Oop. Where have I moved? Yeah, if I'm on the midline, I have to have moved laterally, right? This is a freebie. Okay? So, am I in the hypothalamus still? Yeah, but where would it be? I'm going to put my pen down randomly. Where do I need to move? Inferior? Yeah. So my hypothalamus is going to, what is left of hypothalamus is probably going to be about right there. And it's really hard to tell how far medial-lateral I am from within the hypothalamus unless I can see the bundles that are going either into it to the mammillary body or out of it to the anterior nucleus of the thalamus. All right. And if you look at it in this plane, where will you find it? So what do you use as your landmark to find the hypothalamus? Third ventricle. So, where are we here? Is there hypothalamus? No. Correct. We're just coming in. There may be a tiny anterior bit right here. I think we're just coming into the chiasm. How about here? First of all, are these in the correct order? Am I being a nice guy today? Yes, they are. I'm not always a nice guy. Okay? Is there hypothalamus here? So here's the third. What are these coming down? Yeah, it's the fornix. What's this? Optic tract. What's this? Amygdala. What's this? This? Okay. What are the fibers that are going to do this? Amygdalofugals. It's that very quick, short route that comes out of the temporal lobe from the amygdala and immediately medial, and it hits the hypothalamus right there. Do we have hypothalamus here? Yeah. In fact, we're right about coming down to where the hypothalamic, the infundibular stalk will be. So the hypothalamus will be here and like that. And we're probably just beginning to skim to the anterior nucleus of the thalamus. How about here? Do we have any hypothalamus? What do you think these are right there? Two little lumps. Yeah, those are the posterior edges of the mammillary body. So you're just at the posterior boundary of the hypothalamus there. All right. So it sits here. It's this yellow lump. It's roughly on the midline, flanks the third ventricle, comes out as far as the lamina terminalis, the front end of it, and then comes back with a sort of width to it that comes back as far as the posterior boundary of the mammillary bodies. And in the coronal plane, it gets harder and harder to see, but it's going to be sitting in here, in this zone in here. Okay? So when we think about what's going to be going on here, this is essentially an integrative site where we're going to put together all sorts of different outputs. We're going to have a limbic part of hypothalamus. What do we know that puts in there that's limbic? Hippocampus and amygdala that have outflow, especially hippocampus, that have outflow via mammillary bodies, anterior nucleus, and cingulate. Okay? So that's limbic structures that are projecting through hypothalamus as part of their way to get to cortex, right? Okay. But we also have our regulation of autonomic as well as the other endocrine axes, okay? This is the hypothalamic pituitary axis. And I'll talk a bit about that. For those of you who've had endocrine, you've had a lot more of it. This is basically humoral. This is secreted mediators that act at a distance, okay? And this is going to drive autonomic, so sympathetic and parasympathetic. These affect our internal milieu. These will eventually drive our external world interactions for that purpose, okay? So this is actually a figure from a classic chapter by Nauta and Haymaker, which really described hypothalamic anatomy and nuclear structures. You do not need to learn the names of most of these, okay? There are lots of small ones. They are very hard to see, and they really bedevil what neuropathologists can do. But in this view, you're looking from the medial surface in, okay? And what you can see is there are relatively well-defined nuclear groups that are colored in these sort of, purple, green, sort of rose-colored and teal that run in the medial zone. And they are roughly tiered. There are anterior groups, mid-region groups, and posterior groups. Then you can see these two white matter bundles. What are they? Yeah, this is fornix, and this is mammilothalamic. They form the boundary between the medial zone and this big orange sheet laterally, which is the lateral zone. And at least out of now, we don't know enough about the lateral zone to have any functional definitions about subgroups within it, which is to your luck and advantage. So when we think about this, we break it down and we can conceptualize it this way. The big, wide lateral zone, the boundaries which are defined by the mammilothalamic tract and the fornix plane, that's a plane you can draw. And then we've got areas that we can name. We've got the back part, that's mammillary region. It's right above the mammillary bodies and includes them. We've got the region that's above the tuber. What's the tuber? So the other name for the infundibulum is the tuber cinereum. Okay? Am I the first person to mention this word to you? The tuber, that's an N, cinereum. Okay? So that's the tuberal region. If it's above the infundibular stalk, what are you going to be sending? What type of information are you going to send there mostly? Well, the infundibular stalk is going to be your point of contact with the pituitary below. So it's where you're going to be sending all that endocrine type information. How do you regulate pituitary hormones under the control of hypothalamic releasing factors in order to drive end organs? And then more anteriorly, we have the region that's in front of the chiasm and above the chiasm. So we have a preoptic area and a supraoptic area. And so you can think about them based on roughly what their underlying anatomic landmarks are. So the principles, as I said, are really well-defined nuclei medially, a big mess laterally, an open area for neuroanatomy wannabes to explore. Unlikely you'll get your name attached to anything, but you might. It's really involved in what we think about as integrative function, gathering huge amounts of input onto very small numbers of cells in order to have output. So it's got a wide range of inputs. Its output is both synaptic, the way we normally think about neurons doing, as well as secreting circulating molecules. And the projections are incredibly wide. So it gathers a wide range and sends out a wide range. So when we think about inputs and outputs, there's this hypothalamic endocrine hypophyseal axis for endocrine control. Releasing hormones or inhibitory factors in hypothalamus are delivered by a vascular circulatory system that's unique to the pituitary, and those releasing factors drive pituitary cells to secrete their hormones that will drive adrenals, that will drive thyroid, that will drive testis, that will drive ovary, okay? All of those. We'll talk about them briefly. We have the median forebrain bundle. Where do you think that's going to come from? Forebrain, cortical areas mostly. It'll come from the septal region where the fibers gather, and it goes all the way down through the hippocampus, through the hypothalamus, and on down into the midbrain, because the midbrain's right below. What happens at the inferior posterior portion of the third ventricle? Becomes the aqueduct, which is our landmark for the midbrain. And then the dorsal longitudinal fasciculus that I mentioned briefly a couple of weeks ago that we'll talk about a lot more, that really runs from the hypothalamus down to the medulla. And that's going to be an important driving output. And it will actually, after synapsing, connect further down and send fibers that will go down on to the spinal cord. And this is going to basically be driving a lot of our autonomic components. And then down in the fornix, mammillothalamic tracts and the stria, those are either other bundles that we already know about for input and output. So it integrates those autonomic functions. It deals with stress, okay? What's your major hormonal response for stress? Cortisone. What drives the adrenal to make cortisone? ACTH. Where does ACTH come from? Pituitary. Who tells the pituitary what to do? Hypothalamus. Okay? Corticotrophin releasing factor makes pituitary cells that make ACTH secrete ACTH. When they make ACTH, they drive your adrenal. Your adrenal makes cortisol. The cortisol loop feeds back onto the hypothalamus and the pituitary to modulate it so you can have a way to turn your system on and off. Okay? It also regulates eating and drinking. Anybody who's been to the Society for Neuroscience meeting will know that there are vast acres in the enormous poster hall of posters on control of eating and drinking. How come? If you're a pharma company and you can figure out a good drug that controls eating behavior, you think there's a market? Yeah, there's a massive market for that. It's that people have been studying this without productivity for decades. It also controls temperature regulation, reproductive and sexual behavior, mostly through hypothalamus to pituitary, but also directly. Sleep-wake cycles, as we'll talk about. And basically, it is a critical step in cognitive and cortical arousal. It is an important step that turns on and off the brainstem nuclei we'll talk about on Monday that control that process. So it plays a central role there, and we'll get to that at the end of the morning. So what are inputs? What we're going to do is we'll try and talk a little bit about the wiring now, and then we'll go back through some of the various modules in that after the break. So the median forebrain bundle. This is a reciprocal set of connections where the hypothalamus is somewhere in the middle. There are things more anterior and superior, includes cortical inputs, but septal region that we will come to again on Monday, which is an important structure because it is one of the targets of hippocampus. So remember, the hippocampal fornix splits where? At the anterior commissure. The posterior commissural fibers go to the mammillary bodies. Those anterior commissural fibers go to the medial septal nuclei. And those medial septal nuclei project to the hypothalamus. So we have multiple areas in hypothalamus that are getting our memory content. Okay? We have the fornix input. Okay, so we've got hippocampus input here. We've got hippocampus input here that's sort of two synapses in, as well as lots of other things that go into the septal region. We've got the amygdala, both through the stria terminalis and the amygdalofugal pathway. And why might there be a retinal projection? Yeah, if you're going to do sleep-wake cycle, you need to know something about light. So where are these? Well, the medial forebrain bundle comes from the medial septal region, which is mostly up here and down into hypothalamus. This blue band here is the, what is that? Fornix, postcommissural. These are you can almost see a few of the precommissurals coming in here to the septal nucleus. Okay? Here's the green is the stria terminalis. The dotted green is the amygdalofugal, coming out of that temporal lobe and right into the hypothalamus. And these, hard to read here, are the dorsal longitudinal fasciculus, which is a bidirectional pathway. Okay? So let's think a bit. I got the dorsal longitudinal fasciculus here. No. So this is a slide I showed when we talked about the amygdala, and I was a little rushed at that point because of timing on Wednesday, so I brought it back. Okay? So when we think about it, I said, what are the amygdala outputs? So I've hit several of them here. Lateral hypothalamic area, okay? Ventromedial nucleus of the hypothalamus. We're also going to come to the septal, which is going to feed back into the hypothalamus. Preoptic area. Where's preoptic area? Hypothalamus. Medial or lateral? Medial, because it's got a better name than just being lateral hypothalamus, okay? Here we are, lateral hypothalamus. That's just like the biggest garbage name you could come up with, right? So this is very anterior. It's in front of the chiasm. It's that preoptic, okay? We'll see where that comes later. All right. Hypothalamic outputs. Well, we know a bunch of these already. We know that the anterior nucleus of the thalamus comes from the mammillary body. There is a hypothalamic-thalamic fiber bundle, and it mostly goes to dorsomedial. Dorsomedial projects to what cortical areas? Prefrontal. That huge prefrontal zone is mostly innervated by dorsomedial. So together here, we're hitting cingulate and prefrontal. What are you doing there? Right now it's completely quiet in all of you, right? This is resting activity pattern, right? What's going on in those regions? Sensory processing? Planning, thinking, okay? This is valuing, making decisions. What should I be doing? Which choice should I be making? What's the context in which I'm sitting? And all of that is tightly tied to this autonomic hypothalamic connections. And we know that unlike the fornix, which is mostly unidirectional, okay, so you go fornix, you go hippocampus via the fornix to the mammillary body unidirectionally via the mammillothalamic tract to the anterior nucleus, okay? The connections with the amygdala are bidirectional. Stria terminalis and the amygdala fucals are bidirectional connections, so they are output targets as well. And in fact, I grabbed the same slide that I had about inputs to the amygdala, because if it's an output of the hypothalamus back to the amygdala, it's when you look from the amygdala's perspective, it's an input, okay? And here they are. Where are they coming from? Ventral medial nucleus of the thalamus and the lateral hypothalamic area, as well as all the cortical areas, the brainstem regions alike. But these are the ones that are also reciprocally connected back and forth. So you're sending information in, getting processing, and getting it back. Let's go a few more minutes and try and do some of this before the break. So in the walls of the third, there is an easily recognized nucleus. And it's called the paraventricular nucleus. And when we look at it, it's really easy to see the big cells. Okay? And if they're big cells, we tend to call them magnocellular. Okay? And these are the neurons that secrete the peptides oxytocin, vasopressin. There's a second nucleus that secretes these, which is the supraoptic, which sits right above the optic tract. Okay? Not above the chiasm. If you sat above the chiasm, you would be the suprachiasmatic nucleus. So these sit above the optic tract. Why don't they sit above the optic nerve? Because that's in front of the hypothalamus. So you wouldn't have a hypothalamic nucleus that was supraoptic nerve. Okay? So these project with their axons down to the posterior pituitary where they release these hormones into circulation. There are two other components, one of which is a peptidergic component of little cells, and they secrete thyrotrophin-releasing hormone and corticotrophin-releasing hormone. What do those control the release of? Thyroid-stimulating hormone and ACTH. So they're going to have to do that not by projecting an axon down into the anterior pituitary, but rather by releasing these into the the portal circulation, where you release into a vessel, you have a vein, then you have a second capillary bed before you get back to the heart, and that second capillary bed sits around the anterior pituitary cells so that these hormones act there. Okay? And then finally, we have a glutamatergic component of little cells. And these are the ones that we're sort of looking for. These are finally our autonomic output. This is one of the major sources of things that control things going down. They're both parasympathetic and sympathetic. They will likely innervate them differently because you're never going to turn them both on at the same time. You're always going to be turning them on and off separately. Okay. Emory.
Sorry, what was the difference between the magnocellular component?
So we'll get to this in a bit, but when you think about it, if your pituitary gland is here and has both an anterior and a posterior compartment, okay, and your hypothalamus is here, and you have the stalk of the pituitary that comes down like this, right? For things that are going to the anterior pituitary, they release at a synapse into a vessel, and the vessel delivers the effector down here, where it acts on the cells. If you're coming to the posterior, you have a neuron here that sends an axon down, and it releases its hormone down in the posterior gland.
No, sorry, between the magnocellular and the superoptic.
Oh, they are just in slightly different places, but they are both the same. They are both oxytocin vasopressin. I'm sorry, I thought you were asking between, because these are both peptide, but different pathways. So the glutamatergic is going to project down, and it's going to get inputs. Why do you care about inputs into the from solitary tract and inputs from the spinal nucleus of 5? What are they giving you? So solitaris, what's in there? So taste, visceral sensation, innervation of the stomach, which tells you gives you some information about gastric contents and things like that. Spinal nucleus of 5. What's in it? What type of modality? Let's remember 5. 5 has how many parts? 3. So they are in which way? We can think about the 3 divisions, V1, V2, and V3. Which of those project into the spinal nucleus of 5? All of them. But then we've got our distinct modalities. We've got the sort of, chewing proprioception. We've got the, light touch, vibratory, lemniscal type. And then we've got our classic pain temp, right? Where's the projection for these go? Mesencephalic nucleus of 5. For this, principal nucleus of 5. And for this, spinal nucleus of 5. And what else comes into this nucleus? 7. And 10. All right. So all of that sensation for the head and the same pain and temperature sensations that come viscerally, all of that come in, and all of those actually project directly and indirectly to the glutamatergic portion. And now where are your effectors going to be? Those effectors are the effectors that are parasympathetic. But which parasympathetic nuclei will you mostly go to? Well, what happens in the setting of pain? Your pupils going to change? They do actually a little bit. Not much, because most of that is driven by light. So there's a tiny bit that goes to 3. Where's the next parasympathetic? 7. For what? Minor salivaries and so on. Is that going to be hooked up to this? Yeah. Yeah. Dry mouth. Anybody ever get a dry mouth when you're anxious? No, it never happens. Okay, and what after 7? After 7 comes 9. Okay, parotid. Is that involved? Yeah. After 9 comes 10, dorsal motor nucleus of the vagus. And then after dorsal motor nucleus of the vagus, where's the next stop? Not superior cervical ganglia. What's before the superior cervical ganglia? Spinal cord, intermedial lateral cell column at T1, and T2, and T3, and T4, and so on, and all the way down. Okay? So what gets us there is the dorsal longitudinal fasciculus. Okay? So, let's, before we take the break, find the dorsal longitudinal fasciculus. So it's here in blue. And notice that I showed it to you before in the other direction. It's another one of these bidirectional paths. But now we're thinking about it as descending, and this figure gives you no useful information as to where it actually sits. So if you look at it here, and this is a really lovely, I took the paper's citation off, but it's an incredibly beautiful diffusion, tensor imaging, anatomic alignment paper for these pathways. So if you look at here, in this panel, they are showing you the dorsal longitudinal fasciculus running here in a brown line. The blue here is the medial longitudinal fasciculus and the central tegmental tract. Remember we talked about that a while ago as well? Okay. So here's their picture out of the paper. In order to make it more useful, I rotated it, which makes it really hard to cheat and read the labels. But it means that the brainstem looks the way you expect it to. And they've shown us both the DTI, color-coded on the right-hand side, and where they physically are on the left-hand side. Okay? And so the dorsal longitudinal fasciculus is right here along the wall of the aqueduct. Okay? That's right along the medial surface that came right out of the hypothalamus. And as you move further down, it slides away from the aqueduct, and it ends up right down here in this line of white matter right there that's been present all the time and that we haven't actually ever pointed out and named. Okay? But it's not going to stop in the midbrain because you have to get it all the way further down, right? So you're going to see it and it's going to continue. So here on the left, we're looking into the floor of the fourth. We are the cerebellum looking down at the floor below us. Okay? And you can see that it is going to run laterally out here, compared to the medial longitudinal fasciculus, which is right on either side of the midline. Okay? These are the superior cerebellar peduncle fibers. What direction are they running? Which way do I put the arrow? Yeah, they're coming like this. They're coming from the dentate on that side, across the midline, and up to the red nucleus, and then the thalamus. VL, RN. All right? And as we come down further in the pons, we can look to where they are. Here is the dorsal longitudinal fasciculus right out there. This is the MLF coming down, and we will eventually bring that MLF down to the nucleus of 6. We're not there yet. And if you look here, here's the MLF. This would actually probably be prepositus here, and here's the dorsal longitudinal fasciculus. Okay? This ICP is the inferior cerebellar peduncle. Which olive projects into this ICP? Which one? Inferior olive, same side or other side? Yeah, it's these fibers. The fibers that are coming out of the hilum of this olive go across like that and enter. All right. And where are these headed? Well, we're going down for that hypothalamic control. We need to come into the brainstem, a little bit of 3, more of 7, 9, and mostly 10. Okay? And then down into the cord to the intermedial lateral cell column. There will be synapses along the way, and periaqueductal gray is important for this, and there are a bunch of diffuse nuclei in the pontine and medullary tegmentum that are relevant relay steps here. The major bundles on the way out are the dorsal longitudinal fasciculus, and then these others that are, there's actually a hypothalamic spinal and a hypothalamic medullary bundle of fibers. All right, this is just to try and highlight that there are these relevant nuclei, the periaqueductal gray in the midbrain, and then on the way to the dorsal motor of the vagus, you may well have synapsed in some of these other reticular tegmental nuclei. All right. If you interrupt that inside the brain, you can get a Horner's syndrome. What is Horner's? Horner's is essentially unbalanced parasympathetic, which remains intact with loss of sympathetic. We talked about it mostly if it's out in the periphery, things coming out through the thoracic outlet, the apex of the lung, cancer up there, crushing the sympathetic chain as it comes up the spine and giving rise to it. But you could get it if it happens centrally. If it happens centrally, what else would you expect? Anything? Let's just sit here and look. Say, imagine it happens at this level. Are you going to get a lesion that's going to hit just the dorsal longitudinal fasciculus and disrupt that function on one side of your body? No. It's almost always going to come with lots of other brainstem functions, abnormalities. So if you have lots of other brainstem abnormalities and a Horner's, it gives you some anatomic information. It tells you it's really on that dorsal surface, because that's the only place that those fibers are, right? Okay. So it helps you localize. They are relatively uncommon centrally and much, much more common peripherally, but they can happen. So let's stop here, pick up again at 10 of, and slowly make our way through the rest of hypothalamic function. So, when we think about the things, and I've sort of pushed on this a lot already, these are the different inputs. Did I lose my? No, I didn't. These are those inputs that are going to drive it. Our sense of fear and response and comfort, our sense of memory, all of the decisions. And as I said before, early on, this role of the insula with an asymmetry, this potential asymmetry, not really well documented in other ways, but to the extent that there is any effective relative differences, the left side tends to drive more parasympathetic and the right side more sympathetic activity. So where are those? Well, we've got the amygdala through its both amygdalofugals and stria. We've got the hippocampus from the subiculum predominantly that comes around to the mammillary bodies. We've got our corticals that come via the anterior cortical bundle or the median forebrain bundle through the anterior nucleus. And then we've got things that come in through the dorsal longitudinal fasciculus that are bringing up that information about visceral sensation that comes from the dorsal motor nucleus of the vagus and to some extent from the spinal nucleus of 5. Okay? When we think about the regionality, the further lateral and posterior, the more likely it is a stress response, and the more anterior and medial, the more likely it is a non-stress response, calm, relaxed, and happy. Okay, except for those of you who like stress. Okay, so anterior, and you're in the right place. Increased passivity, increased satiety, decreased temperature. So let's think a little bit about a couple of these types of controls. So, baroreceptor. We know that the carotid body out in the periphery at the bifurcation is essentially our blood pressure sensor. Okay? It's innervated by cranial nerve 9, inferior jugular ganglion. Where does that synapse? It's a visceral sensation. Solitary tract. It's a form of taste. Okay? You're tasting your blood pressure. Okay? Your output is going to be through what? How do you regulate your blood pressure? Cardiac rate. Okay? So how much you pump and vascular resistance. Okay? Those are the two things that you can change. How do you change heart rate? Vagus and some other direct sympathetic tone. And how do you change your peripheral resistance? Vasodilation, vasoconstriction, which is sympathetic control. Okay? So you got to wire these two parts together. Okay? So there's an ascending component from the solitary tract into hypothalamus, and you descend down to dorsal motor as well as down into your sympathetics. Okay? Makes sense. I mean, you know what the input is, you know what the output is. We just never wired them up before. Okay. Next, bladder control. Hypothalamus is involved in this. Okay. There's input to what's known as the pontine micturition center. Remember, in the cord, we have this balance between sympathetic motor tone or parasympathetic motor tone, depending on who you believe. But we've got basically smooth muscle innervation from the intermedial lateral cell column. And we have skeletal muscle, striated muscle innervation from the anterior horn at S3. That's the sphincter. So that if you constrict the sphincter, you relax the bladder wall and allow it to fill. The bladder itself has a reflex, like a knee jerk. It reaches a certain stretch, and what happens? It contracts, and you release the sphincter. So you can basically have a neurogenic bladder. It's running on its own. It has no control from above. But you know that you now, although you didn't as an infant, have voluntary control, and you have control in context. Okay? And that control in context, as in response to fear, and others, runs through the pontine micturition center, descends down to the parasympathetic and onufs, okay? But you drive the system in order to control what is otherwise this reflex loop of filling, which is a completely passive process, driven by nothing other than what? What's going to determine the rate with which you fill the bladder with urine? Renal perfusion, okay? Because renal perfusion is essentially the sole determinant of water movement, okay? You do a little bit of pumping, but if you perfuse them, you're generating urine at a fixed rate. It basically runs through the collecting system, down the ureters, and into the bladder, and sits there in the bladder. It gets bigger and bigger and bigger until it says, too big, and it empties. All done. Okay? And remember, we talked about the difference between the neurons that are in the intermedial lateral cell column up here, which are cholinergic and go to a ganglia, so they have ganglionic transmission, versus the motor neurons that are down here that drive the external sphincter, which have nicotinic neuromuscular transmission. Here they are essentially at a neuromuscular junction. Hypothalamus also is critical for our control of pain. But none of these things, they all have a relay station on the way out. And for pain, the most critical relay station is in periaqueductal gray matter. Okay? There are a bunch of others in the reticular formation and the raphe, but periaqueductal gray matter is the most important. And we talked about this at the very beginning when we talked about where pain is first, where's the first pain synapse? I burn my fingertip, okay? Sensory information comes from this in through, C5, C6, into my spinal cord. Where does the first synapse happen? Yeah, substantia gelatinosa in the dorsal horn. What do the second order neurons do? Cross the midline and project in the spinothalamic tract on the contralateral side. That first synapse sits there in the substantia gelatinosa. And I mentioned when we talked about it that that is in fact the modulatory site where endogenous opioids project to gate pain, so that in the setting of stress or whatever, the pain transmission is down-regulated. Okay? Where do those neurons that release those opioids project from? Periaqueductal gray. So you've now got your hypothalamus, talking to your periaqueductal gray, projecting down to control the pain pathway as it comes in from the periphery. So we've completely closed that loop that I mentioned on the first day of class. Now we've finally gotten to it. So you can respond to pain or ignore pain in the context of external information as well as your internal processing that's gone on in your prefrontal cortex that drives your hypothalamus to say, tell the periaqueductal gray to release mu opioids at the terminals, bind them to the receptors, and decrease transmission from the stimulus coming in. All right. Let's talk about the endocrine system. So we have to separate out things that go via anterior and posterior pituitary. In the anterior pituitary, Projections mostly go to what's known as the arcuate nucleus that sits in the walls of the base of the infundibulum. Okay? We have a portal circulation. What's the definition of a portal circulation? Yeah, it's a circulation in which there are two capillary beds in series. Okay? Normally we go big artery, smaller artery, arterial, capillary, venule, bigger vein, larger vein, back to the heart. Here we will go artery, arterial, capillary, artery, arterial, capillary, then venous. So two in series portal capillary beds. And what you do here is you release either a releasing factor or an inhibitory factor from the hypothalamus that will eventually affect the anterior pituitary. The contrast is the posterior pituitary, where you've got axons that run from the hypothalamus all the way down the stalk, and they release into a circulatory bed in the posterior gland, but that's not portal. It's just a capillary bed. Okay? And that's the oxytocin and vasopressin that we need. Oop. So where are these relative nuclei? So the arcuate nucleus sits right down at the inferior portion here. Here is our stalk. Coming down, this is the infundibular stalk. And as we'll see, things that come from the infundibular region in the arcuate nucleus will project into the first capillary bed, release it. We've got the portal vein here, and then the second capillary bed out here, and down here we're in anterior. Whereas the nuclei, such as this is here supraoptic nucleus, but also paraventricular, and this would be the magnocellular portion of the paraventricular, project their axons down. They don't synapse on a neuron, they synapse on a vascular bed. So, neurons down and in, neurons to the first capillary, to the long hypophyseals, and out to the next capillary bed. Posterior pituitary, paraventricular, the magnocellular, as well as the supraoptic. These are peptidergic neurons, okay? But they generate this 9-amino acid protein, oxytocin or vasopressin, depending on sequence. Vasopressin is critical for water control in the kidney. I can't remember how it works. I remember nothing from renal pathophysiology because I was not taught by Albert. I know something about what it does, but really nothing. And for my purposes, all you need to know is that it controls water regulation at the kidney. Okay? But how do you know what you need to do about water? Why do you regulate water at the kidney? But what are you trying to maintain? Why do you care how much water? Well, you care about circulating fluid, so you care about both intravascular volume, but what else? Osmolality. How do you know about osmolality? You don't have like a microanalyzer that figures out the sodium concentration, the potassium concentration, the chloride concentration, the large insoluble anions, and figures out and does the calculation. You don't have anybody know how you actually measure osmolality in a lab? The easiest way to do it is by changes in freezing point. And so you actually you measure things like freezing point depression. So you do thermography where you basically cool and you measure or heating or boiling point thermometry. We basically measure how many kilocalories you need to put in or withdraw from a system per degree of temperature change. And at the point when it freezes, you all of a sudden have a large phase transition. So you can measure the phase transition, and by knowing the shift, you can calculate the osmolality. Okay, that's how you actually measure it. But you don't have a way to do that in the body. So what do you have? You've got a series of places where the blood-brain barrier is not as tight, and you are able to measure osmolality. And they are right next to the ventricle. And what's next to the ventricle? CSF, CSF fills the ventricle, but what nucleus? Paraventricular nucleus. And what does paraventricular nucleus care about? Osmolality. Okay? It's like, these things are near each other. So there's this sense for circulating molecules. And in the hypothalamus, there's something known as the vascular organ of the lamina terminalis. It's a funny vascular bed in the very anterior wall. And then the area of the median eminence has an abnormal vascular wall, vasculature. Okay? So you're able to sense the osmolality because neurons are exposed not to CSF and CSF as it comes through interstitial fluid, but they're exposed to intravascular osmolality. Because that's what you care about. You don't care about waiting for your CSF osmolality to change in response to your circulating osmolality. You care about circulating osmolality. So you have to be able to sense it. There's also something known as the subfornical organ, which has very unclear function, but the area postrema, which is right at the very inferior end on either side of the bottom end of the fourth ventricle, is chemosensitive. It is very sensitive to circulating molecules, and it drives vomiting. Yep. No, it's not flow. It's not flow. It is actually measuring in some way, essentially, oncotic pressure. And the actual transduction mechanism for it is not known. But well, it's not a pressure like blood pressure. It's essentially the oncotic pressure. You know, you're looking across a membrane. What's the force that drives water based on ionic fluxes? And the actual mechanism for the channels is not known there. Right?
Is the CSF osmolality regulated independent?
Yeah. It's regulated very tightly by choroid plexus. And it doesn't change in response to circulating osmolality. So it's not a good marker. And even if it were a marker, remember, you've got a big flow volume of it, and unlike blood, you have terrible mixing of CSF, okay? You don't have a pump that moves it around. You don't have it going through, you know, out of a chamber, through a valve, into a pipe where you're going to have turbulence and get mixing. You're just secreting it, and it sort of slowly diffuses, and it's being resorbed, and there's net stable balance. But you don't have a circulatory mechanism. So it's really it's not really homogeneous. In fact, we can see that by if you introduce dye in the old days in order to look for disc compression of cord. The best way to do it was to put somebody in an X-ray machine, put a catheter into the subarachnoid space, and shoot radio-opaque dye in, and then pivot them and watch it travel through. And they put dye in that was relatively viscous and dense, and you could see it travel in the subarachnoid space, and if there was a bulging disc, you would see that it would get stuck as an angiogram. All right, it was Kike and then Emery. It does, I mean, so you don't get much CNS change in potassium concentration in hypokalemia. It's much more cardiac toxicity that you get with it. You can make it, I mean, in a dish you can make it hyperkalemic, and we do that to do block, but you don't get significant CNS block with circulating hyperkalemia, mostly because the changes are pretty small in CSF.
Sorry, I was just wondering, is the subcortical organ, is that part of the economic?
Yeah, so it is sort of, so it sits right at the top boundary, actually right here. So here's the subfornical organ. It's sort of at the very edge of the, so the hypothalamus sits roughly like this. Here's the mammillary body, okay? So the subfornical organ is right there, but what is more relevant for hypothalamic sensing is probably the organ vascularum of the lamina terminalis. Oop, forgot. So if you lose vasopressin, you basically can't keep water in, and the symptom is diabetes insipidus. This is different than diabetes mellitus. Diabetes mellitus, your sugar is too high, your sugar pulls out. As you get rid of the sugar in the urine, you pull water with it for osmotic reasons in the kidney. Here you are just not holding on to water, diabetes insipidus. You basically treat it by taking a synthetic version and shooting it and sniffing it. DDAVP, which has got D amino acids, so it doesn't get broken down, and you can treat it. The opposite, syndrome of inappropriate ADH. Okay? Now, much of this happens outside Much of this is if some tumors, such as carcinoids, make ADH. But you can get it with intracranial trauma, where you just start releasing it inappropriately. And in order to keep this, you basically need to fluid restrict, because the person is hanging on to water. So you basically need to drive water out by increased salt loading to get them to put more water out in urine and decrease the amount of water that they bring in. Oxytocin drives uterine contractions in the early phases of labor. So it's critical for induction of labor. And the synthetic form of it is Pitocin, used for induction. So if you don't initiate, the factors that initiate parturition, those of you who had repro last year will remember, is really poorly understood for initiation. Okay, so you can do it synthetically. Lactation initiation is also driven by oxytocin. It's associated, particularly in animals, with behavioral changes. And it carried this whole issue about socialization. There's all sorts of weak data on changes in oxytocin receptors in the setting of autism. Is this sort of a hormone for social function? I think that's all massively overinterpreted. But those are both released via pituitary, posterior pituitary, with axons that run all the way down. In contrast, we have the anterior pituitary under the control of hypothalamus, but with the release of releasing factors up here at the top end, the portal circulation, and then the release. And I'm not going to worry about any of the end organs here, but really just to highlight that we have both positive and negative control here. We have several that are positively controlled. Gonadotrophin releasing hormone drives secretion of both LH and FSH. Which of them it drives depends on estrogen and progesterone levels in the anterior pituitary, and that's why you can get alternating regulation of LH and FSH in order to create menstrual cycle and support pregnancy during gestation. CRH drives secretion of ACTH, as well as the other peptides. What's the best well-known of the other peptides two other peptides that come with ACTH out of its precursor? So the precursor's name is, anybody remember this from last year? POMC. What's the O? Opio, melanocorticotrophin. So melanocyte stimulating hormone and beta endorphin, okay, one of the opioid peptides, okay? So what happens if your adrenals are failing and don't make ACTH and or don't make cortisol, and your pituitary is driving them as hard as it can by making ACTH, and in order to do that, you need to drive the pituitary as hard as you can by making CRH. What else do you get? Hyperpigmentation, okay? So the bronzing of Addison syndrome is because in the pituitary, you're making melanic MSH under the control of CRH. Thyrotrophin releasing hormone for thyroid hormone and growth hormone releasing hormone for growth hormone. We also have two that are under negative control. Growth hormone is in fact dynamically regulated with both a positive and a negative with somatostatin. That's why it's called that. Okay? You ever wonder why somatostatin was called somatostatin? It's because it is for growth of body, it is the statin. It is the opposite of the growth hormone releasing hormone. And prolactin is under the negative control of dopamine. Okay? The consequence is that if masses grow in the pituitary, they may secrete one of their hormones. But a mass in the pituitary that grows and squeezes and decreases the blood supply coming into it from the hypothalamus can lead to hyperprolactinemia. Not because the tumor cells not because there are tumor cells making prolactin, but because you've lost the inhibitory control. So if you release the inhibitory control, you make prolactin. Okay? And dopamine antagonists can also lead to hyperprolactinemia. Andy and then Debbie.
I think Emery also asked this earlier, but for the supraoptic versus paraventricular and the posterior pituitary.
For our purposes, we count them as the same.
There's no distinction that we care about.
Not that I care about.
Okay.
If you treat with dopamine analogs for the cholesterol, does it affect other dopamine functions?
So there are slightly different dopaminergic receptors here. So dopamine receptors are very, very heterogeneous. So there are ones which are specifically targeted for this. Cabergoline is the one that gets used clinically for people with prolactinomas. That's the one, because it's under negative control, without a positive control, you can sometimes get away and control tumor growth by blocking, by giving a dopaminergic agonist. All the rest of them, they basically are surgical treatments. So let's talk about eating and drinking. It's critically and centrally controlled in the hypothalamus. So hypothalamic lesions often lead to abnormalities here. There's this incredibly intricate interaction between gut, what's happening in the gut, what's happening systemically, and there's an enormous amount of really, really complex, ugly signaling that goes on. It used to be thought that everything was good. There would be a nucleus that makes you hungry. There is a nucleus that controls water control, so why isn't there a separate nucleus that controls like breakfast and one for lunch and one for dinner, and one for, midnight meal? A concept that used to happen for physicians but doesn't exist anymore. So when we think about these, they're both short and long term. There's the immediate response when you eat, okay? When you put food in your mouth, okay, glucose or most glucose and other compounds in the mouth elicits salivation, okay? Independent of consciousness. Food in the stomach initiates acid secretion. It initiates a whole other set of things, and it initiates peristalsis. What controls peristalsis? Autonomic nervous system is critical for control of peristalsis. So all of that is the every time you eat, every time you are hungry. That's the short term. But then there's the long term, which is going to also be conscious of things like body fat, as well as all sorts of other metabolic long-term situations, your glucose metabolism, your insulin level, your glucagon levels, and a whole lot. And there are an enormous number of hormones and receptors that feed back, and I love this figure because it's completely incomprehensible. But it really shows you that when you think about it, we'll talk, so we haven't talked much about nucleus accumbens, dorsal medial hypothalamus, lateral hypothalamic area, ventral tegmental area that we'll talk about on Monday, ventromedial hypothalamus, paraventricular nucleus, arcuate nucleus, nucleus of the tractus solitaris. All of these show up on both the make me eat, make me not eat network. They share some of the same molecules, and they all share the same molecules with each other. So they're trying to find a pharmacology that's going to target and make people not eat is really far more complicated than everybody hoped it would be when they began. Because if you target any one of these, you have a network system, you have a network problem to try and understand, where you may have targeted lots of nodes in a network, and that may not give you what you thought you were going to get if you had a single simple circuit. When we think about how these interact, this is a figure from paper, it's now a little while ago, but some of these circulate like ghrelin, they activate a receptor, they gate calcium, activate proteinase K, PKC, activates the lipase that generates arachidonic molecules, and those arachidonoglycerols are endogenous cannabinoids that work on presynaptic cannabinoid receptors, okay? So that's critically involved, as most people know, in gating hunger. And anybody who's been down at the corner of Route 9, across from the firehouse, I mean, this is a short line outside the dispensary there, but we all are aware of the impact of cannabinoids on hunger. Where does that happen? It happens in the hypothalamus, and it happens by gating all of those same circuits. Temperature. Last Friday, I was probably febrile while I was lecturing. So how does that happen? What drives it? So the answer is that your body temperature is incredibly physiologically tightly regulated. Okay? It is very much a marker of pathologic state if it deviates. We all know this. In the setting of viral infections, we become febrile. Our temperature goes up. Why? Well, the answer is hypothalamus. Okay? So the hypothalamus, so we have ways of dissipating heat. Okay? We can sweat, which if you are in a low humidity environment, works. If you are in a hot, humid environment, it doesn't do much. But anybody who's been in, sort of high desert, where it's 100 and something degrees, discovers that, in fact, if you stay hydrated and keep sweating, it actually is an effective cooling mechanism, okay? You would not know that living here, but it is elsewhere. Vasodilation allows you to bring heat to the surface. And the only way you can generate heat is essentially by uncoupling metabolic pathways from functional motor activity. You basically have to burn ATP to make it. And the most typical way that we generate it is by shivering, where basically ineffective muscle contractions give you all of the ineffectively captured energy out of the ATP. You keep cleaving and in order to keep moving your muscles. That generates excess heat. The critical areas for gating this in the hypothalamus are the preoptic and anterior hypothalamus. And that's the most critical site. And then the posterior hypothalamus is really as an output device. But what we have there are essentially warm neurons and cold neurons. Okay? So this is an elegant bit of circuitry to give you a function. So what we've got are neurons that are sensitive to temperature, and they start to fire when the temperature gets above their set point. The further away from their set point their temperature gets, they are warm, they respond, the more they fire. Okay? Those get innervated by peripheral sensation. So the goal is, if you are in a hot environment, what do you want to do? You want to cool yourself down. So you are sensing hot. Okay? You're in a hot tub at, 120 degrees. Okay? It is uncomfortably hot. What is your body going to try and do? Going to try and cool you down. Okay? So in order to do that, these warm neurons start to fire, and the warm neurons are balanced by cold neurons, and cold neurons run in the other direction. So when you are cold, the cold neurons fire, and they fire more from the set point the further they get away. But they're not driven by information from the outside. They are driven by the fact that when the warm neurons fire, they're being inhibited. So the less you fire the warm neurons, the more you fire your cold neurons. So what happens when you get infected? What happens when you have a viral infection? What goes up? Cytokines. Cytokines are responsible for everything. A whole bunch of them turn out to be pyretic. They make you have a fever. Okay? They also can access hypothalamus the same way that osmolality can. Okay? These are large protein molecules. They don't normally get into the CSF. Okay? But instead they can through the organ vascularum of the lamina terminalis, which is right by the preoptic anterior hypothalamus. So now you've got the cytokines. Turns out that what the cytokines do is they activate and increase cyclic AMP levels. They turn on protein kinase A, which decreases the excitability of warm neurons. So if you decrease the excitability of warm neurons, what happens? Instead of starting to fire as you go above, 37.5, they don't start to fire until you go above 41 degrees. So what happens? Your temp rises, and they don't start regulating you. You've set your set point at 41. And that's a fever. And when you remove the stimulus, your set point will return back down to where it's normally set.
So is that implying that naturally our fevers are just driven by...
They're driven as a component of cytokine response.
No, I meant like if we didn't have any... I just meant like it seems that it's decreasing the excitability of neurons, which means that naturally like a fever is just caused by body.
Yeah. So basically what you've done is you've set you are always balancing your temperature, just the same way you're balancing everything else. And you're not aware of it, but you're vasoregulating and the like, and doing a little bit of sort of uncoupling and shifting. And so by decreasing their excitability, you've essentially effectively shifted the set point so that you are now sort of realigned to be maintaining yourself at some higher temperature. Okay? Trace? I don't know what the initial molecular. So some of it is basically, the level of information that you're getting from the peripheral temperature receptors, and those are thermally gated channels. But I don't know what the specific molecules are that control the exact temperature. And
Where is the input coming from for the warm neurons?
they're getting direct sensory temperature sensing neurons.
But everywhere? Or
Yeah.
Are they integrating like all the signals?
They're integrating the whole thing because your temperature doesn't go up if one hand is in a hot water box. You put your hand there. That's very different than having your whole body in an environment. So they are sampling across the whole body. They're essentially getting a sort of global average to sense it. It's why you get various different responses, how much you expect exposed to hot and cold. Yeah. So there are situations in which people have sort of poor temperature regulation, more so than being misset. They tend to fluctuate, which probably reflects not sort of single neuron but circuit abnormalities. We've got like 6 more topics, so yeah, why don't we finish them up later, okay? Because I want to sort of keep going through these. I do want to mention hypothalamic lesions as a component of this disease. This is a picture I showed you before. So tell me what you see. So we've got things that are the wrong color, right? So where are they? Let's start from the bottom. This is where are we? Medulla. Yes, it's upside down, but it's still the medulla. Okay? I mean, it doesn't change who it is depending on whether it's right side up or upside down. These are the pyramids. This is the, fourth ventricle, and we've got, what are those? Those normal pigmented nuclei? No, we've got punctate areas of hemorrhage in the lateral walls of the lateral ventricle and in the brain around it. Where are we here? Midbrain. Is that lesion? No, what is that? Stantia nigra. How about this? Yes, so here, this is the aqueduct. So what's going to be right here? MLF and dorsal longitudinal sort of a little over here. But what else, what nuclei? Oculomotor. So eye movement abnormalities. Where are we here? Yeah, we're in thalamus. What part? So here's the anterior nucleus. This is the dorsomedial. Dorsomedial projects to prefrontal. Where are we here? We're in thalamus. What do we see? Mammillary bodies. We're in mammillary bodies. Where are we? Hypothalamus. Right? This is the posterior portion of hypothalamus. These are the fornicocele fibers coming in here, okay? That's mammillothalamic tract leaving right there. What do you see? Hemorrhages there. So these people end up with behavioral changes, eye movement abnormalities, and memory disturbance. Wernicke syndrome, okay? This pattern along the midline, the midbrain, from the hypothalamus, and down the brainstem, associated with thiamine deficiency. The epithalamus. So we're now at the last sort of littlest structures. So we're going to talk about 2 of them, the habenula, and then we'll talk about the pineal and circadian rhythmicity. So epi is the little tag end. And when we look at it here in the midline section, we can sort of see we can actually see the pineal gland sitting right here. It is coming right off the posterior portion of the third ventricle, and there's a little recess here, which is appropriately known as the pineal recess of the third, okay? The pineal gland is actually neuronal, okay? As is the habenula, and the habenula is this really small little lump right here that sits at the posterior edge, sort of right on the posterior surface here of the pulvinar, okay? So if you think about this, this is the pulvinar viewed here from the posterior surface. Here we're coming down. This is going to be they call centre médian back here. We're coming in just into the very posterior. It's a slightly angled cut, because it's a horizontal cut, actually, because this is posterior and this is anterior. This is the third ventricle. This is coming towards the pineal recess. And on either side back there of the third, we've got the habenula and then the pineal gland behind it. So the habenula really is associated mostly, as best we can tell, with reward-type behavior, and it's wired like hypothalamus, even though it is attached to the thalamus. Okay, it's much further back. How do we know we're further back than the hypothalamus? Because what's the posterior boundary of the hypothalamus? Mammillary bodies. So we are way behind. The mammillary bodies end here. So the hypothalamus ends here. We're going to find the habenula back here. So we are way away from it, but it is wired like it. Okay? So it has lateral and medial nuclei, but its inputs come from a fiber bundle that, just to make your lives truly miserable, is called the stria medullaris. Okay? It's not the stria terminalis. It's not the lamina terminalis. It's the stria medullaris. Okay? Nothing I can do. Runs on the surface, and it comes from various similar sources, limbic structures as well as septal nuclei and olfactory. These are the same sorts of things that go into the amygdala. Right? It has outputs that go back down into the midbrain through the wonderfully named fasciculus retroflexus. So if we think about it, we've got this habenula sitting way back here. It's got inputs that come from mostly in front of the hypothalamus. Our hypothalamus is going to sit here, and it's going to have targets that are down here in the midbrain. So we've got a fiber bundle that runs over the surface of the thalamus in here, and this basically bends backwards and comes down like this to anterior midbrain. So it is coming back in the direction that the inputs came from above, but heading downwards. And that's why it's called retroflexus. It bends backwards. And it comes to the interpeduncular nuclei, which will be between the peduncles. Is the interpeduncular nucleus therefore going to be dorsal or ventral in the midbrain? So here's the midbrain, here the colliculi come around, here the peduncle, okay? Here's my aqueduct. Where's dorsal here? Ventral. Interpeduncular nuclei sit down here, okay? Between those peduncles, they're in ventral, okay? But the habenula is relatively posterior. It's all the way back at the back end of the third, so that's what's bending forward is the retroflexus. Okay. So when we think about that, we've got the stria on the surface here coming forward, back to the habenula here, and then this is going to project back like this down here. In between the peduncle is the retroflexus. Okay? And it functions a lot in reward-type behaviors and responses. There is no structure too small to be further subdivided. So this is, in fact, a paper from Nauta, from when I was taking his course. So this is what he was doing in his lab at that point, which was taking the lateral habenula and dividing the lateral habenula into a medial lateral habenula and a lateral habenula, and demonstrating that they're in fact wired up differently. Okay? So there is no structure that cannot be subdivided. The habenula is really interesting as a neurobiological structure for this reason. It was found, and this has been replicated by others, that in the habenula you have individual axon terminals that co-release transmitters. Well, that's not a big deal. We know that many neurons co-release GABA and a peptidergic co-transmitter. GABAergic and neuropeptide Y. GABAergic and somatostatin. I mean, that's not uncommon. Lots of our inhibitory interneurons do that. But these are not co-releasing GABA and a peptidergic pair. They are co-releasing GABA and glutamate. And think about what the physiology you get from a neuron that provides both excitatory and inhibitory stimulation is. Okay? How are the synapses positioned one to the other in order to do that so that an individual action potential that drives transmitter release gives you some meaningful form of transmission? Okay? How do you sort where those synapses are and which ones get the storage mechanism to put glutamate into a vesicle versus put GABA into a vesicle? Okay? This is an incredibly intriguing issue, and it is found only in the habenula, which makes it really tough for people to study, because if you haven't taken my course, you don't know where it is. All right. So the pineal gland, we're almost at the end. Okay? So the pineal gland, it's a gland. What does a gland by definition do? Secretes stuff. It secretes stuff that does what? Acts. This is like pulling teeth. Okay, what's the critical feature about where it acts? At a distance, okay? It's different than a neuron that secretes at a synapse, okay? The adrenal gland is a gland because it secretes at a distance. It releases cortisol, it reduces aldosterone, it releases epinephrine, and those have distant targets, okay? So the pineal gland does that. Descartes called it the seat of the soul. Anybody have any idea why? Yeah, it's a midline single structure. You only have one of them. You do not have a left soul and a right soul, okay? And you cannot lesion just the left soul versus the right soul, okay? It's got a very differentiated type of neuron called a pineocyte, not surprisingly, and what it makes is melatonin. Okay? Makes it from tryptophan through a series of enzymatic steps, and its control is bidirectional. It is a direct central projection that comes from hypothalamic structures, that's why we talk about it here, but it also has a sympathetic innervation. Okay? So the sympathetic nerves that innervate it, where do they come out of the nervous system? Spine. The only place you have sympathetic projections is in the spinal cord. Okay, so that's got to be the answer. Someplace in the spinal cord, probably relatively high in the thoracic region because they're projecting to the head. Okay, so there you're going to go from there to the ganglia, superior cervical ganglia. Superior cervical ganglia will project an adrenergic projection into the pineal gland, and that drives melatonin synthesis. But the rhythmicity of it is in large part controlled by the suprachiasmatic nucleus that we'll mention in a moment in the hypothalamus. So that suprachiasmatic nucleus, which is your rhythm generator, drives from there down through dorsal longitudinal fasciculus, down into the spinal cord, through the hypothalamic spinal fibers, all the way down, out through the autonomic preganglionics, up through the sympathetic chain, synapse at the superior cervical ganglia, up onto the pineal gland, and tells it when to make melatonin. So the suprachiasmatic nucleus is a rhythm generator, but it is also an entrainable rhythm generator. And what typically entrains it is exposure to bright light. Okay, so morning. So your free-running clock is not 24 hours. It tends to be on the 25-hour. You put people in a room with no stimuli, and they free-run not at 24 hours. You are normally entraining your clock to be morning, okay? And you do that by light, and that comes, if you're going to be doing it by light, you do it from the retina. And similar to the pupillary response, this is driven by the intrinsically photosensitive retinal ganglion cells, not photoreceptors. So it's not photoreceptor, it's not visual perception dependent, but light falling on the retina, and it drives them to entrain the pacemaker cells there. Suprachiasmatic nucleus basically projects and is going to control all of that rhythmicity. And the rhythmicity is not just melatonin, but in fact, your morning cortisol peaks. Okay? How do you control your morning cortisol? Well, your morning cortisol is your adrenal in response to your pituitary under the control of your hypothalamus. So suprachiasmatic projects to those regions in the hypothalamus that control that. Same thing for the thyroid hormone. Same thing for all sorts of eating and drinking behavior. Same thing for being awake. How do you know that you are awake? Well, your brainstem has essentially told your hemisphere to wake up. Okay, we'll talk about that on Monday. And also you have daily fluctuations in not just blood pressure and the like, but in temperature. And those are driven by suprachiasmatic through the hypothalamus and out. So where is the suprachiasmatic nucleus? It's above the chiasm. So what part of hypothalamus will that be? Anterior or posterior? Anterior. Okay. Medial or lateral? Medial, because it's got a name, right? If it doesn't have a name, it goes in the lateral box. Okay. So the last thing we need to touch on is what's called, and this is the segue to Monday, is we have in our brainstem, and we will discuss this in much greater detail on Monday, a whole lot of structures that secrete mostly aminergic molecules or amino acid derived molecules, catecholamines, serotonin, histamines, and so on. And these are what keep us awake and alert. They basically tell the cortex to be engaged, and when they are downregulated, the cortex is able to basically become quiescent. But what controls them and what drives them all is the ventrolateral preoptic area in the hypothalamus. So this is the central controller that generates the balance between is that whole set of pathways in the active mode or the inactive mode. And this is the hypothalamic contribution to sleep-wake cycles. Okay? So, the VLPO controls this whole brainstem network, and the brainstem network that we'll meet on Monday controls everything else. And these are antagonistic to each other. So that the way the circuit works is this simple balance that if you run these brainstem nuclei, here this is the locus ceruleus, the raphe, and the tuberomammillary nucleus, all of whom we will cover on Monday. When they are firing, you're awake, and they're inhibiting the ventrolateral preoptic area. If the ventrolateral preoptic area is firing, you're asleep, and it inhibits this. Okay? But what do the engineers think about this design? What's the problem with a system that looks like this? It's too what? Well, they're too similar, but how do you know which state you're in? What happens? Something like this, you're either in one state, and then you flip. Can you flip back? Yeah, you can basically bounce back and forth and not have anything that keeps you in one state or the other. Okay? It's an unstable pattern. So what you have instead is an additional group that you can modulate. And that's the orexin-containing neurons. Okay? So the orexin-containing neurons, orexin's a peptide that was originally isolated because it is the opposite of, what's the opposite of orex? Anorex. What do you think about for anorex? Not eating. So it was isolated in the context of feeding behavior, but it turns out to be critically important for regulation of sleep-wake. So we've got these orexin-containing neurons, and now they are they drive the raphe, okay? And they are inhibited by the VLPO. So that you have, by adding that in, the system becomes able to stay in one state much longer, and then when it transitions, stay in the next state for a long time. The consequence is that if you disrupt that circuitry, you end up with a disease. And the disease is what's known as narcolepsy, cataplexy. And the real problem is that what we see when you look at somebody is that they look sleepy. That's the narcolepsy. They look sleepy because, in fact, they never actually sleep. Okay? Because they are unstably going between sleep and wake all the time. So symptomatically, they complain of excessive daytime sleepiness, but what they have is sleep fragmentation. They never really get significant stretches in REM sleep. And then they also have this phenomena of cataplexy, which is loss of muscular tone in response to strong stimuli, often emotional. Sometimes laughing, sometimes sudden noises. They often have sleep paralysis, which we normally experience briefly as we go into sleep, but their entire system that says be awake, be asleep, drops them into the no muscle activity in response to cortical activity. That's the sleep paralysis, that atonia of sleep. Okay? If you happen to go into that suddenly, well, if I went into that state while I was standing here, what would happen to me? I would fall down and collapse. Okay? And that's the cataplexy. They also get these dreamlike hallucinations that we don't normally experience. So cataplexy can be seen not just in people, but in animals. I went and I found that this is a dog responding to the mail being dropped in. I don't know about your dog, mine does this too. And it has just become cataplectic and collapsed. It just became completely atonic and fell down. It's asleep. Okay? It's asleep. And then you'll see in a moment. Here it is, happily sleeping. It's awake again. It's just pivoted back and forth, that little seesaw, which should be down for a couple of hours, and then up for at least 15 minutes if you're my dog, and then down for a couple of hours again. It's just bouncing back and forth, and that's what happens in people with narcolepsy, cataplexy. Turns out, and this is really interesting, those of you who want to learn more should seek out Tom Scammell at the BI. There are genetic forms of this, and they're associated with mutations in either orexin or the receptor for it. So you lose the ability to regulate staying long time in one state or long time in the other state. So instead of sleeping enough so that you actually get the benefit of sleep, you sleep for a short period of time, then you're awake. You sleep, you sleep. And then when you wake up during the day, you're sleepy. And you continue to go between sleeping and waking on short alternating patterns. There are sporadic forms which look like a neurodegenerative disease, where just those neurons seem to selectively degenerate. Leads to the interesting question, how much sleep do you need? So everybody has their own set points. There are all sorts of definitions, but what I love from this paper of theirs is that it highlights, boring lectures do not cause sleepiness. They only unmask it. All right. All good things have to end. And next Friday there will be an exam. Yeah, aw, right? I'm not a softie like some of my peers, where people do all sorts of, hop through hoops for me. There are no exams. I will post some more review videos this afternoon when I locate them in my archives. I will also post a prior exam, one that I wrote a couple of years ago, so you can see what it looks like. I'm pretty sure I have found any of the errors in my answer key, but I will also separately post the answer key. I would encourage you not to look at the answer key until you go through the exam and use it as a self-assessment. You're free to do that. Work with each other on it, whatever you'd like. The intent is to help you get reviewing. We will have relatively little new content next week. Monday will be a discussion of the diffuse systems, those systems that control arousal. And there's a handful of them that we'll cover. And then on Wednesday, I will go through a bunch of clinical cases to try and highlight, thinking about symptoms and deficits, where would it be? What sort of place would you put it? Learn a little more about the patient. What does it help you understand, and so on. I will probably try and divide you up into small groups based on where you're sitting and pass out like cards with numbers so that I can call on group 7 to answer and I can call on group 3. I will give you the sequential information that you're going to see in advance as part of the slide deck, so you should at least take a quick look at it, but really be thinking about responding to it as though it were framed in this form of a multiple choice question, and seeing it for the first time in class, looking at it and thinking about what you would say in response to it. I have at least 2 cases set up like that, and I'm hoping to get a third one organized. So we'll do that for about an hour, and then in lab on Wednesday, I've written a lab exercise with a lot of very specifically intended review exercises that really should be highlighting and try and unite across all of the content. So, with that, have a lovely weekend.